All right, good afternoon. Let's go ahead and get started. Welcome to today's webinar, Uncovering the Unseen, Understanding, Planning, and Costing for Brain Injuries Within Medical-Legal Litigation. This webinar is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Gigi Liggins, and I'm the moderator for today's webinar. This webinar is anticipated to run about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the duration of the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to the recording along with a short survey that we ask you complete. We're excited to host today's webinar and do look forward to an opportunity to work with you. I'd like to start by introducing today's presenter and life care planning expert, April Pettengill. April Pettengill has over 33 years of experience as a registered nurse. She worked in the hospital setting in geriatrics, pediatrics, telemetry, and orthopedics. For the last 30 years, she has been a case manager for work-related injuries and illnesses. April has extensive experience with catastrophic injuries, and in 2004, she became certified as a nurse life care planner. In 2005, she expanded her areas of expertise by attaining the Medicare Set-Aside Consultant Certification and has been writing MSAs ever since. April currently works as a case manager for catastrophically injured patients to keep her hands-on clinical skills active. While working in the community, she has had the opportunity to work with patients over the continuum of care, including high-tech pediatric patients. April has been a member of AANLCP since 2004, actively working on the conference committee and most recently as secretary of the CNLCP Certification Board from 2007 to 2018. And with that, April, the audience is yours, so I'm going to stop sharing and pass it to you.
Thank you very much. And let me see if I can get this going here. All right. Okay. So thank you very much for attending today. I really appreciate you being here. And Gigi, thank you for that wonderful introduction. Today, we're going to talk about brain injuries. In the United States, a person has a brain injury about every 7 seconds, which makes it one of the most common types of injuries. Recent attention in the medical community has focused on concussion protocol, recovery protocol, chronic traumatic encephalopathy, and blast injuries. Even with all of that attention, brain injuries often go undiagnosed and undertreated, and a source of frustration for the patients and their families. I refer to brain injuries as a silent disability. It's not like you can look at somebody and say, oh, you've got a brain injury. Occasionally they have medical issues that go along with the brain injury that are obvious, but you don't often know that they're caused by a brain injury. Even with
April,
the same...
we don't see your screen just yet. Are you sharing it?
I thought I was, but hang on. Let me try. I thought I was. All right, bear with me. I am technically, there we go, here we go. Let's see. Can you see me now?
Go.
All right,
yes.
There we go.
So from current slide and we should be good.
All right, there we go. Hey, look, that looks
fantastic.
Better.
Thank you.
See everybody. Thank you. So today we're going to start with a brief introduction to the different kinds of brain injuries We'll talk a little bit about brain anatomy in a very generalized way. Obviously, neuroanatomy is extremely complicated. And so all we're trying to do today is just to help you with your understanding about how brain injuries can work within the medical legal arena. So the different types of brain injuries are, they're all kind of a subcategory of a bigger category called an acquired brain injury. So that is defined as any injury that is not hereditary, not congenital, not degenerative, or induced by birth. That birth injuries are kind of a subcategory of that. Traumatic brain injury is the result of an outside force applied to the brain. I'm going to see if I can move my little dude here. There you go. It's a result of an outside force applied to the brain. It can be closed or it can be penetrating. Anoxic brain injury is caused by lack of oxygen to the brain, and that can be for many different reasons. We'll talk about these in more detail in just a minute. This is just kind of a brief, quick introduction. Then we have our birth injuries, which are often a combination of both traumatic and anoxic. And the last category that I want to talk about today is one you may or may not have heard about, and it's called diffuse axonal injuries, or DAIs, which is the stretching of the axons of the neurons in the brain. Don't worry, we're going to talk about that anatomy just very briefly a little later on. So first off, we have our traumatic brain injuries. Obviously, as I said, they're from an outside force. It can be from a fall, or it can be from a sports injury. We've seen some newsworthy information about the chronic traumatic encephalopathy with the football injuries. We're seeing other sports also starting to take a very serious view on brain injuries, and including hockey, and well, you may not be familiar with it, but also in the martial arts industry. Motor vehicle accidents, you see that a lot in litigation. Sometimes they're very serious, and other times you don't often know that the person has a brain injury right away. A blow to the head, maybe it's in a fight. Whiplash injury can be from a motor vehicle accident, from a fall, anything that causes the brain to go backwards and forwards. Heaven forbid a gunshot, but they are out there. The link that's here on the slide is for an annual surveillance that the CDC does every year. And this is the most recent one, which was done in 2019. And they report on all of the incidences of brain injury in the United States. Now, they can only count the ones that have been hospitalized. So in 2019, there were approximately 233,135 TBI cases that required hospitalizations, and an additional 64,300 that resulted in death. This number does not include emergency rooms, urgent care visits, people who don't seek treatment but have sustained a brain injury. Males are 2 times more likely to be hospitalized and 3 times more likely to have fatal TBIs over the females. Children from age birth to 17 had 16,000 hospitalizations from TBIs or brain injuries in 2019. They used to say that the highest incidence of brain injuries occurred in young males. That's actually now shifted to the over 75 population as our general population ages, and we have more baby boomers getting up into the higher ages. So next up, we have anoxic brain injuries. And as I noted, those are a result of lack of oxygen to the brain. It could be from smoke inhalation, chemical exposures, drownings, accidental hangings situations, and also strokes. And there are two basic types of stroke. You have hemorrhagic stroke, which is when there's a rupture in the blood vessels. And you can see here in this drawing where the blood vessels are leaking out of the veins or the arteries into the brain. And then you also have ischemic, and that means that the arteries or veins are blocking flow to the vessels of the brain, and all of this causes brain cell death. Next up, we have birth injuries. And I do want to spend a little bit of time on this today, just because birth injuries are, I see a lot of them in litigation. I do a lot of plannings for babies who have had injuries either during or immediately following birth. They can be the result of a cord being wrapped around the neck, either inside in the placenta or during birth when the baby's being born. The cord gets tight and causes the brain to lose oxygen. You can have a baby that gets stuck in the birth canal, and that can cause both anoxic and traumatic version. So babies' heads are not fused, so they're designed to kind of smush as they come out. I mean, that's a gross kind of thought, but that's what they're designed for. But sometimes if they get stuck or they require forceps to be removed, that can cause additional trauma to the brain. Something that happens occasionally is meconium, and that's the first stool that the baby has. And if they have it in utero, sometimes that they can breathe that in and cause breathing issues, which can lead to lack of oxygen to the brain. What can happen with babies that have brain injuries is they end up developing cerebral palsy or CP, and that is defined as impaired muscle coordination as a result of brain damage before or during birth. And it has a wide variety of severity. It can be from somebody who just has a mild difficulty walking, maybe a foot that doesn't fully extend, to babies who are unable to do anything for themselves. They can't eat, they can't speak, they can't move around. Everything has to be done for them. So it's a huge, huge variety of constellation of symptoms. So diffuse axonal injuries. This is always part of traumatic brain injury. They result from the force of the brain moving back and forth inside a hard shell of the skull. And it causes the brain's neurons to get caught and stretch. And in a minute, we're going to show you a picture of what a brain cell looks like, the neurons, so you can see where that stretch occurs. This occurs in 40 to 50% of TBIs requiring hospitalizations. They have some level of DAI. They're almost always seen with some level of loss of consciousness. It could be a few minutes up to 6 hours or more. One of the things that's very concerning about DAI is that it does have a very high mortality rate. And it is not seen on CAT scan. It is often missed on MRI, only if it's very severe. The preferred test to diagnose the DAI actually isn't the MRI, but it is diffuse tensor imaging, diffusional tensor imaging, DTI. In 2018, the Journal of Brain Injuries did a metadata, which is a review of all of the research that's out there on DAI. And they found that people who have this diagnosis are 3 times more likely to have an unfavorable outcome with brain injuries. And then in 2020, Brain, the Journal of Neurology from the UK, did a study. They published a study that they did of 55 people, which isn't a huge study, so obviously they're going to need to do more. But they did a longitudinal study where they had people who were diagnosed with a DAI. They did a brain MRI, or sorry, DTI, at 3.5 years post-injury, and then again at 12, a little over 12 years post-injury. And what they found was very interesting, was that there was significant neurodegeneration and atrophy of the brain compared to a control group of those people who had the DAI diagnosis. So maybe I didn't say that very clearly, but the ones with the DAI were substantially more likely to develop neurodegeneration, both in the gray matter and the white matter of the brain. So now we'll talk about the parts of the brain. And this is, again, it's a very quick overview. It is very cursory. It is the 100,000-foot view. We're not going to get into the specific details of all of the brain parts, but it's just for your understanding so you can get an idea of what the brain does. So here we have a great illustration of all the lobes of the brain. We have the frontal lobe, which most people are pretty much aware of. That's right in the front, right behind this nice thick skull that we've got here. That controls motor. It controls problem solving. Speech production is done in this area. It also, even though this slide doesn't say it, it is the emotional control of the person. So if you have someone who's having difficulty with anger, or they are just depressed and sad and not able to get out of it, sometimes that's related to a frontal lobe injury. In the years past, many years ago, if they had somebody who had these types of injuries, they would do a lobectomy and they would take out part of the brain to resolve those. And thank God we don't do that anymore. The other part of the frontal lobe that is very important is what we call executive functioning. And that's your get up and go. That's your ability to remember to do your brushing of your teeth and getting dressed and changing your clothes and doing your day-to-day activities. Executive functioning is initiated in the frontal lobe. Next up is the occipital lobe. The occipital lobe is where our vision comes from, and that's kind of like a band right across the top of the head, right behind the frontal lobe. It does our visual reception and interpretation. Vision is actually one of the symptoms of brain injury that goes very underdiagnosed because, and we'll talk about this later on when we talk about symptoms, it often presents as other symptoms, and people don't realize it's actually coming from a vision issue. We have next the parietal lobe, which is kind of heading toward the back. That's where our touch perception and our body orientation. So that tells us where we are in space. It tells us if we're getting close to something. It can be whether something's hot or something's cold. That's all the perception that happens in that parietal lobe. Going across, we have the temporal lobe, or the temporal lobe right here. This is where your vision, your hearing, your language, your comprehension, your memory, that's all stored in this one little side of the brain. underneath of it is where we have our hearing. And that's very important to remember, because sometimes when you have a blow to the side of the head, there's some hearing issues. Or if you have even some blow to the top of the head, it can smush this down and it can affect the hearing. You get symptoms like tinnitus and just loss of hearing in one ear, just suddenly. Next up, we have the cerebellum, and the cerebellum is where our motor control comes from. Motor function comes from. It's right at the back of the head, right where those two little knobs are at the base of the skull. It's in conjunction with the frontal lobe. Between the two, that's how we get our motion going and how we do our everyday work. Then the last one is brainstem. So brainstem controls our involuntary functions, our heart rate, our breathing, our digestive system, things that we don't think about, muscle contraction. Well, you may want to move your arm. It's actually the brainstem that tells it how to do that. Excuse me. One thing that's not listed here that I want to just briefly touch on is what we call the corpus callosum. And that's a network of nerves that connect the sides of the brain. So you have a right hemisphere and a left hemisphere. And then in between is this network of nerves that allow for brain signals to go from one side to the other. It's very important in terms of knowing that your right side of your brain controls the left side of your body and vice versa. In DAI, this often gets damaged, and as a result, that information isn't crossing and it can lead to problems. Next up, we have ventricles. So in the middle of your brain, you have holes, and that's okay. They're supposed to be there. These help produce and hold your cerebral spinal fluid. That's what keeps the brain lubricated. That's what helps with some of the removal of problems in the brain, diseases in the brain, viruses, bacteria, and in hydrocephalus, which is, you've probably heard that terminology before, that's where that ventricle system either gets filled up with blood or extra fluid, and it pushes the brain up, and the brain doesn't have anywhere to go because it's right up against the skull, and that can cause problems with cell death around the brain. So to help with controlling that, oftentimes they will put in what we call a VP shunt, or a ventroperitoneal shunt. That's a little tube that goes from those ventricles down the neck and into the abdomen. It has a pressure sensor on it, and if the pressure gets too high, it then turns on, opens a valve, releases the extra fluid, and it gets into the abdomen where it's absorbed, and then it's all taken care of by the body. So you'll see that sometimes in patients that have the hydrocephalus. All right, so here we have our neurons that we were talking about earlier with the DAI. So if you think about the neuron as an octopus, all of these little arms work together with the next one to bring all of your nerve system signals from one cell to another. Now remember, these are microscopic. You can't see them with the naked eye. You can't see them on an MRI. You have to see them on a very special microscope. Along the cell are these myelin sheaths, and those sheaths they allow those electrical signals to go from one nerve to the next, to the next, to the next, in speeds that we cannot comprehend. If those myelin sheaths get damaged at all, if it gets stretched and these pop, it reduces the ability of those cells to transmit information. And that can lead to the cell death. It doesn't have a purpose anymore, so it just dies. So that's where your DAI comes in. When these neurons get stretched, the signals can't get through, then the cells start to die. So then we have the coverings of the brain, and obviously the outside you have the scalp or the skin. That's the part where your hair is attached. If you wiggle your head, that's what moves, is the skin. Underneath that is the periosteum. That allows for blood flow around the scalp, keeps the bone moist, protects it. And then the bone. Underneath that, you have the dura mater. That is highly, it's a tough membrane, and it needs to be, because bone is actually not smooth. There's a little bit of holes in it and things that can get caught. So the design is there so that it allows for sliding and not getting caught. However, if it slides too much, it results in a tear, and you can have a subdural hematoma, or you can have a subarachnoid hemorrhage, because our next layer is the arachnoid, which is where all the good stuff is. All of the fluids that transmit the blood flow through the brain, the lymph nodes, all of the lymph all goes through there. Then you have, next is the pia mater. And that's a very fragile membrane that covers the brain. It's got neurons and cells and fluid in it to help keep the brain going. Then you have your gray matter, and underneath that, your white matter. So those are the layers of the brain. Very basic, very basic. All right. So let's talk a little bit about brain injury symptoms. It's likely that in the litigation arena, the symptoms that you're going to see are going to be long-term. Most of the time, if you have a brain injury, a concussion, and it resolves, that's pretty much the end of it. So the people with long-term symptoms are the ones you're going to see in the medical-legal arena. So let's talk about the symptoms of concussion. So we've got headaches. That's a big one. They'll always ask you, do you have a headache? How are you feeling? Do you feel nauseated? Do you feel dizzy? Do you have any confusion or slurred speech? In mild brain injuries and mild concussions, these things will resolve either after a few hours or maybe after a few days. When they start getting longer and hanging on, then you have to start to treat these symptoms. And so it's very important to make sure that people understand that you're just treating symptoms and you're not really treating the cause of the symptom. So once the brain gets damaged, the only way it can recover is by creating new pathways, those new cells, to make that information go back and forth. And sometimes the brain never recovers, and people are left with these symptoms for the rest of their lives. Two areas that are very much underdiagnosed and undertreated are vision changes and, well, it's not on here, hearing changes. So those are things to keep in mind. All right, so your DAI symptoms look very much like TBI symptoms or concussion symptoms, and indeed they are. But one of the things that kind of can key you into problems with DAI are difficulty walking and balancing. If that consistently is a problem for the person, you really need to get a good evaluation. Behavioral changes, those emotional changes, that's that frontal lobe. That's the last place that's going to get signals. So if you've got nerves that are coming up the spinal cord and trying to get to that front to be able to work, and you've got mixed up messages in the middle, it's going to take make the person very, very frustrated. And emotional changes that just don't recover. They go from being, your best friend one minute, and the next minute they're tearing you down because you looked at them crazy. Those are all things that need to be addressed and could be related to DAI. So what is it that makes brain injury so complicated? It's the varying levels of symptoms, and it's the constellation of symptoms. Everybody's different. You can have someone who has two people that have the same injury, and they have very different results from that. And a lot of it depends on what their age is and what their pre-injury health is. Genetics play a part in it. Symptoms can be masked. So in other words, if you have someone who's got dizziness, is it coming from a problem with the brain injury, from the cerebellum, or is it coming from a vision issue? Is it an inner ear problem? That needs to be teased out, and it needs to be figured out what the cause is, so then it can be appropriately treated. Symptoms are often chalked up to other illnesses. So if you have somebody who maybe had diabetes prior to the TBI, and now all of a sudden they're saying, well, you know what, my numbness and tingling is worse, they're just gonna, they could potentially have a doctor say, oh, it's just your diabetes, it's it's to be expected, when in reality maybe there's a problem with the brain injury and the nerve transmission. Eventually, after a person's had a brain injury for a while, the family starts covering for them, or they start to learn how to cover for themselves. So they may not have a good ability to get the words out. So they will use connecting phrases like, and, oh, or they change the subject. Maybe they're having difficulty with information processing, and being in social situations is very disturbing for them. So they avoid it. They make excuses. I don't want to go today. I don't feel well, that type of thing. So that's what makes brain injuries extremely complicated. The other thing is symptom management. Sometimes the treatment for the symptoms gets overwhelming and extremely complicated for a brain injured person to manage. If you've got someone who's not processing information very well, and the doctor's saying, here, Fred, here's your medication, I want you to take it 3 times a day, and come back in a month. Well, all he heard was medication and come back. They may not get it. Oftentimes treatment just doesn't work. If you're treating symptoms, and you're not really understanding what the problem is, what the cause is, then you could throw treatments at people and it's just not going to make them better. It gets extremely frustrating for the people around the person themselves, their work. Everybody gets super frustrated with the fact that this person is not the same, and they're having problems just getting better. Why aren't you better? My gosh, that was a year ago. You should be over that by now. Symptom management can be extremely expensive, where the costing comes in. The cost for medications and treatment is, can be overwhelming. And if the person doesn't have good insurance, or you're looking at a delayed settlement for their litigation, then they're having to try to figure out how to pay for their treatment. And it can be very time consuming. If you've got someone that needs to go to therapy 3 or 4 times a week, and they're trying to work and they're trying to manage their life, it's very difficult to do. So how do we plan for the future? With brain injuries that are complicated and expensive and frustrating. So how do we do that? In the medical legal arena, it's all about your team. You got to get together a group of people who can help you build a case, who can figure out what's going on and really understand brain injuries. So the doctor that is probably the best overall type of doctor to help you with a litigation is a physiatrist. They're an expert in physical medicine and rehabilitation. They know physical therapies, they know neurology. Oftentimes they'll do EMGs and that type of thing. So they understand, that process. You want to get some good evaluations by PTs, OTs, speech therapies, neuropsychologists. The gold standard for determining cognitive issues is a neuropsych report. They look at information processing, they look at memory, they look at reading comprehension, math comprehension, speed of information processing, which becomes very important because oftentimes if you're putting information out at somebody and they're just staring at you, it may not be that they're not hearing you. It may be that they're having difficulty getting that information in, processing it through their brain, and then getting a response to you. Neurologists and neurosurgeons oftentimes are a good addition to your team, depending if you've got someone who needs some surgery or they have a shunt. Your life care planner is going to put together the costs for you. The vocational expert is going to look at, can they go back to work? What can they do for work? And your economist will help you in the litigation by determining present value, lost wage earnings, and that type of thing. So I talked a little bit about the physiatrist, and you want someone who really does have a background with brain injuries. They are going to do a good evaluation, physical as well as a mini mental evaluation, put it all together for you and give you an idea of what is this person looking like for the future. As I noted, the therapies are very, very important. Physical therapy helps with balance issues, and if they have a severe brain injury and they're trying to learn how to walk again, if you have somebody who just needs some help with endurance, which is fatigue is a huge issue after brain injuries. If you think of the brain injury as a person who has like a cell phone battery, and at the end of the day, their battery needs to be charged again, oftentimes PT can help with increasing that endurance. Occupational therapy, they're really good at the fine motor. So if you've got someone who has a problem with that area of their brain and they just need some help with their fine motor motion. Speech therapy is excellent not only for people who are having difficulty speaking, but also cognitive issues. So if they're having problems with memory or executive functioning, the OT and the speech working together can really help come up with a treatment plan for that. As I said, the neuropsychology report is really the gold standard if you're looking for before and after comparisons about what is affecting the person. I can tell you right now, though, getting into a neuropsych is very, very difficult. There are not a lot of them around. I have a patient right now that's been waiting since January for a neuropsych, and it doesn't look like we're getting one till probably November or December. So neurology, once the brain injury has stabilized, there's not necessarily a lot to do unless the person has seizures. Then you're going to want to have that evaluation just to make sure that they're on the right medications. After a while, some people can be weaned off of their seizure medications, but again, that's a call for a neurologist to make. Neurosurgery, again, if they have surgical needs for the brain. Your vocational expert, they're going to work on what can the person do? Are they disabled? Do they need retraining? What kind of retraining are they going to be able to do? Do they need supported employment? So that's their area of expertise. The life care planner is going to be putting the whole picture together, figuring out the cost for all of that information, all of that treatment plan that your team members are putting out for you. And then the economist is the person who's going to do present value. They're going to look at the lost wages. I've had a few economists who actually even do some things around home care or assistance care costs. So planning for the future medical is very expensive, and the money absolutely needs to be considered. This is your damages in the litigation arena. I just want to touch briefly on the cost of medications for headaches, which is oftentimes a very long-term and debilitating part of brain injuries. They have come out with some great headache medications. They are super expensive, Amavig or Ubrevely. They are a once a week injection, some are once a month, and they can run from $600 to $1,500 a dose. Oftentimes people go for Botox injections for their headaches. Again, super expensive. And they need to be done by a physiatrist or a pain management so that they're getting done correctly. We haven't talked a lot about counseling, but we've talked a lot about frustration. And that is an area that is going to come up. People are going to get frustrated, and a good way to deal with that is counseling, and that can add costs to your plan. Therapy. When you're talking about recovering from this type of injury, once a week isn't going to cut it. You're going to need to have regular intensive therapy, potentially going back periodically to deal with issues. The brain, if it's a permanent type of injury, they're going to need regular therapies. Sometimes they need assistive devices. If you've got someone that's on a ton of medication, a medication dispenser might be appropriate. Bathing aids or assistive devices, wheelchairs, any of that kind of stuff, that all costs money and it needs to be replaced. Home care is probably one of the most largest, let's put it that way. It's one of the largest numbers in a life care plan in a lot of cases. And you need an expert who can tell you whether it should be skilled, unskilled, or if you need some people with specialized training in brain injuries, someone like a life skills aide. Future planning with your work and recreational parts, that's going to add costs. If you've got someone who was an avid skier before And, now they're not able to ski, but they could participate in an adaptive ski program. That's going to cost money, and it needs to be figured into long-term planning. Vocational, your vocational expert is going to let you know, what do they need? Is it something where they need training? Well, that's going to cost money. That's going to need to be included in your litigation. When you talk about long-term care for a person, you need to identify who's going to do that. Is it going to be family? Is it just at home, or do they need it also in the community? I can tell you now, as probably some of you are aware, that the availability of people in the community to provide care is getting harder and harder to find. And as a result, the cost is going up. 5 or 6 years ago, you could get a person to come in, an unskilled person could come into the house for $20 an hour. Now you're looking at $30 to $35 an hour for that same person. And there's not availability like there used to be. And there's also a decrease in the public funding sources. Well, that's not necessarily something to think about in litigation. It may be for the person going forward. I want to talk quickly about a life care plan. So it's a comprehensive document that addresses both the medical and non-medical needs of the person with a brain injury or a life-altering injury or illness. Typically, a life care plan has a medical summary. It has information about the person's current status, what they're doing, what they're able to do, how they've changed. And then it has tables, and those tables list out everything that is needed, how much it costs, how often it has to be replaced, if it's a durable medical item, or how many hours the person needs, that type of thing for care. And then it will have an annual and sometimes lifetime costs involved in it, or in the document itself. It's usually very comprehensive, and sometimes can be many, many pages long. So best practices for your litigation with people with brain injuries. You have to put together your team that has a knowledge of brain injuries and how those injuries impact function. They also need to have an understanding of what that impact has on the individual and the family, both from a cost perspective, from a frustration perspective, from what's going to happen down the road. And you really need to look at long-term care. It's pretty easy sometimes to be like, oh, this is going to resolve in like 5 years, so it's a one-off on this. But long-term care is extremely expensive, especially like if someone has to go into a facility. Those need to be addressed in your litigation packages. So let's see. Here we are. We're at the questions standpoint. So does anybody have any questions? Gigi, do you want to take it over?
I will. Thank you so much, April. You did a phenomenal job. I'm sure that our attendees have learned a wealth of information. So at this point, we're gonna shift to our Q&A segment, and I do ask that you use the Q&A feature within the Zoom dashboard. So if you're unfamiliar with Zoom, when you use your mouse, you'll look down at the bottom and you'll see Q&A, or you'll also see chat. We prefer Q&A, but we'll also accept and be watching the chat box in case you do have a few questions. But to kick us off, here's one question that we frequently get, and it's regarding cost research. Where and how do you get cost research for some of the things that you mentioned in your presentation regarding TBIs or brain injuries?
Yes, so costing can come from different different sources. If it's a medication, for example, you can get that from pharmacy. There's also websites like GoodRx that you can utilize. Medical costs, you try to get from the providers who are treating the person. Sometimes you can use databases, which are becoming more and more common in life care plans or in litigation. They are national usually, and then there's a geographic factor that you have to include. So obviously, treatment in Dallas, Texas is going to cost different than it is in Boston, which is going to cost different than it is in, rural Kansas. So that's why they have the geographic factors. In terms of equipment and things like that, you can get costing from Amazon, web pages, local providers of durable medical. Ideally, you want to have costs that are relevant to the individual.
Yeah. All right. Thank you. Here's the next question. Given the complexity of brain injuries, how do you determine how much treatment to provide or plan for?
Yes, so that's where you work with your team as much as you can. You're going to put together that nice team that we talked about. They're going to give you some ideas about what they would expect. So your physical therapist is going to say, yeah, we would anticipate 3 times a week for 12 weeks, or they might say, whatever their recommendations are. You as much as possible. Now, if you're on the plaintiff side, you can actually go to the training providers, get their input on what's going on. If you're what they expect to anticipate for future care. If you're on the defense, then you can work with your experts. You can look at medical records to see what their utilization has been in the past. You can also draw on the expertise of your team. So they're going to say, hey, people with this kind of injury, with this kind of result, typically have X, Y, and Z for treatment plans.
Okay, thank you. Another question, I think this is asking you to put on your life care planner hat in respect to working with a patient or a claimant with a brain injury. Do you always get to see and evaluate that patient?
Interesting question. If you are on the plaintiff side, yes, pretty much always you want to be able to not only see that patient, but see them in their home environment where they're, doing their day-to-day stuff. What does their house look like? Do they need home modifications? We didn't really even talk about that today. There's watching how they interact. And, when you read a medical record, it may not give you a good idea of what someone's limitations are, but when you sit down to talk with them, you might get a feel for, oh, you know what, they're starting to learn how to cover their limitations. So from the plaintiff side, that's essential. Defense, if you're on the opposite side, you may not get that opportunity. I always like to ask just in case, and in a few times I have had that opportunity to be able to meet the patient when I do defense cases. If not, you hope that there's things like day in the life videos or other information that will lead you to what does this person look like on a day-to-day basis.
Okay, awesome. As we near the end of our presentation, I just would like to point out the services that we provide here at MLCC. Hopefully folks can see my screen. But we'd like to remind you that we offer services for both plaintiff and defense, including life care planning, medical chart review and chronologies, medical and life plan projections. This is kind of a shortened life care plan, Medicare set-aside services, legal nurse consulting, expert witness services, and a cool product called a focus estimate of care. So we'll give it another few seconds or so to see if any other questions show up in the queue. But while we're waiting on that, in the meantime, I'd just like to say again, thank you for joining us for today's presentation on brain injuries. And thank you so much to expert April Pettengill. On the screen below, you can see her contact information as well as our web address where you can learn more about the services that we provide. Additionally, this recording will be published on our website within about 24 to 48 hours. And for those of you who've attended, we do ask you take a moment to complete our survey. It looks like, April, we don't have any other questions. So with that, we'll say thank you and have a good day, everyone.
Thank you very much.
Bye-bye.
Bye-bye.